Are we ready, Dr. Wundes?
Yes. All right. All right. Hello, everybody. I guess this is the official start of our this isn't grand round. Sorry, this is our 5 New Things series, orchestrated by Dr. Kreutzfeld. And so today I get to introduce Dr. Wundes, who will be telling us about 5 new things in MS. Annette came to us from many places in Germany. I was just looking at your CV. So medical school in Dusseldorf. And then one thing I did not know about you is Annette did 2 residencies, one in psychiatry and one in neurology, one in Cologne, and now I don't remember where the other one was. That's why I tried, that's why I didn't remember. And then came to us in 2006 and did an MS fellowship, and thankfully has been here since, and is now the director of the MS Center over at Northwest Hospital, and is one of our very important go-to things in all things MS. So panicked emails from Dr. Oates many times, right? So thank you very much for teaching us like you always do, Annette.
Thank you so much for this kind introduction. Let me get this settled here first. And I warn the people online that I'm supposed to stand here, but that's not what I typically do when I have a talk. So I will try to adhere to it as best as I remember. So today our topic is 5 amazing things in MS. These are not even loosely associated with each other, so I will hop topics quite a bit among those, and I hope that you find the selection interesting. The first thing, so I will dive without further ado into these 5 topics. The first thing is that we actually got 3 drugs FDA approved in the area of MS last year. And so I want to introduce you to those new additions to our repertoire of MS treatments. The first one may look quite familiar. It's Copaxone, so glutamate acetate, and it's something we have been using quite a bit in MS. But there's a new formulation available, and it allows patients to have basically shot-free days. It's a 3 times a week formulation. And it was tested in a randomized controlled trial. It was not tested against the existing Copaxone, but against placebo, and has pretty much replicated the original outcomes in the original pivotal trial, which led to the approval of Copaxone in the first place, by reduction of the relapse rate by roughly 34%, reduction of enhancing lesions, and other MRI markers. A few real life issues with this drug. So the original drug is 20 milligram daily by subcutaneous injection. It's still available, and people ask me often, oh, is this now double the volume I have to inject? It is not. It's higher concentrated, so the same 1 cc or 1 milliliter they have to inject. And there's a new tweak to that. Earlier this year, the FDA has opened the doors for a generic version of Copaxone to be approved, and Copaxone is actually a biologic, so it's a biosimilar. Copaxone is made out of 4 amino acids, and what I put down here today, so the approved version is open the door for approval of Glatopa, and as of yesterday morning, 8 a.m., the information on the slide would have been correct that the release date and the cost are not known. But yesterday, without further ado or any announcements, we got all these phone calls from the pharmacy saying, hey, by the way, we're switching your patient from Copaxone to this Glatopa. So this is a new era for us, and so we don't really have any idea about costs. Obviously, the whole topic of escalating costs related to MS is insane, no question about that. And but then all these drugs come with a lot of support to our patients as well. There's financial support, so many times these drugs are covered to a certain degree by the insurance, and there's a high copay, which the companies haven't taken over this far. And then they come also with extra services like infusion nurse traveling to the patient's home, providing injection training. I have not specific details yet if this is available in this formulation as well. I am told it will be, but I have no specifics available at this point. So this is the first of 3 drugs which were approved in 2014. And then there's a new drug which was approved in 2014, which is called Pedigree. Pedigree is also basically a revised version of something which has been available for a while. You can casually think about this as Avonex extended release. This is not how Biogen would call it. That's not how the FDA would have called it. But it's basically the Avonex molecule was taken to the Biogen researcher and says, make it stay longer. And what they did is, don't ask me the details about what that means in real life, but they pegylated the interferon molecule, and that allows the molecule to stay longer. One important difference on a real life level compared to Avonex is that this is a sub-Q injection versus Avonex is an IM injection. Just for real life, it took me actually a while to realize that. In the trials they did a 2-year study on this pegylated interferon beta 1A. They had a 1-to-1-to-1 randomization between placebo versus this Pedigree every 2 weeks versus the Pedigree every 4 weeks. Again, we don't have a comparison with the originator, the Avonex molecule by itself, but again, we have pretty much a replication of the original outcome data in this trial, what was originally seen in the Avonex trial as well. The drug was, as I said before, was tested every 2 weeks and every 4 weeks, and basically every outcome measurement, every 2 weeks was superior towards the every 4 weeks. So this is a version which then was moved forward towards the FDA and is now available to our patients. If there are no questions, I will move on and introduce you to the third drug.
How often did you have to use Avonex?
Once a week, sorry, I should have mentioned that. Once a week.
Once
a week, I am, and now we go every other week sub-Q. So 2 injections a month.
And then so how does that compare to Avonex?
In terms of efficacy?
Yeah.
I have no trial to tell me other than that I can compare a little bit apples and oranges in terms of that in MS, because MS patients are so heterogeneous, you need to have a head-to-head trial to really make good comparison efficacy outcomes. But if we compare one placebo-compared trial to another placebo-controlled trial, they basically pretty much replicated what was originally seen in the Avonex trial. So I have no reason to believe that it's very different, but I cannot scientifically argue that it has exactly the same efficacy either.
Avonex is about to turn generic too. It seems like in both cases the drugs are trying to make a new one that is now.
Kind of who should
You are
think
so
about that?
suspicious.
You should
So
think about it.
suspicious.
Yeah, so kind of like, I would say that even more on the Copaxone side, because on the Copaxone side, there were data for a long period of time available that these other formulations 3 times a week would probably work as well. On the Avonex side, I don't think we had good data to tell us that it was working at this time before this came out. But also, they probably, I anticipate, saw their patent expired a few years down the road. I think that was maybe not all altruistic reasons towards less injections for the patients, yes. Am I now officially on record with saying that?
You are.
I am, okay.
Are there any differences with regard to flu-like side effects?
Yeah, interestingly. So I actually have obviously asked the patients as well. So if you look at the clinical data, the occurrence and severity of flu-like symptoms seem to be similar. But if you ask the patient who have been on both, they tell me that they also have extended or delayed flu-like symptoms. So some of them had to adjust the day and the time when they give their Avonex. They have the similar amount of flu-like symptoms, but a different timing compared to the injection. I've not had a single person on Avonex who went to Pedigree for less injections and went back to Avonex again because they liked Avonex better. I haven't had a single patient with that. Okay, then I will move over and will introduce you to something new to our repertoire, not only a formulation, but something new at least new in the world of MS. Alemtuzumab is an agent which is previously available for certain types of leukemias, a so-called CD52 antibody, and it results in a very intense and prolonged depletion of both B and T cells. You can think about it, or I explain it to my patient as a modern chemo. It is specifically reserved for those who have had insufficient response to at least 2 of the standard approved drugs because of safety concerns, which I will review with you in a second. The dosing schedule is quite interesting. So in the first year, people will get 1 infusion a day, 5 consecutive days. They will not do anything for the rest of the year. 1 year after their first cycle, they will repeat 3 infusions. And then almost all patients in the study who were followed to 5 years did not need a 3rd cycle. So the rest of the time, for a 5-year time frame, they did not require any other medications. This drug was tested not against placebo, but against Rebif, which when the drug was designed, you can think of, was considered to be more of our more potent agent. This was obviously before the arena of our orals became available, so you need to see that in context that we have no comparison data to our orals or agents we know are more potent than Rebif or consider more potent than Rebif. And it has, compared to Rebif, has significantly decreased the relapse rate by roughly 50 or 50+%. It had also shown a benefit on less EDSS progression in at least one of the 2 pivotal trials. But then there are a number of safety issues to consider. Infusion reactions are very, very common, so these are not easy to tolerate infusions. Interestingly, in the world of MS, this agent, which has been used in cancer before, causes thyroid dysfunction in 1/3 of the people, including really bad type of thyroid dysfunction, meaning need for thyroidectomy, Graves' disease. This is not observed in the cancer population, so there's something funny or unique using this drug in an autoimmune disease. It has, as you would expect, when you deplete B and T cells, an increased risk of infections, and there are multiple black box warnings for several things, including serious and life-threatening infusion reactions, fatal immune conditions. So ITP was seen, the first time ITP was seen was in somebody who had a fatal bleed and did not adhere to blood work. And had to pay a very hard price for that. And then everyone was screened for it. They found a few more cases which were responsive to regular treatments and no further complications or fatalities. And then there's increased risk of cancer. So some cancers were observed, including thyroid cancer. The next bullet point tells you, if you think about this to be a convenient treatment with 2 cycles in 2 years and then you're good for 5 years, here you're immediately robbed of this illusion, because people will need monthly blood work and urine samples for 4 years after the last infusion, which translates basically into 5 years of monthly blood work and urine samples for the vast majority of people. And there are no live vaccinations after somebody has started on this treatment. So it's clearly something which, yes, it will expand our repertoire, but I don't think about it that this is something we will go to very fast and quick, but we'll have probably for selected patients as part of our repertoire. Any questions before I move on? Oh God, you're all silent. Okay. So, topic. Yeah, sure.
Just given how long-acting that treatment is, hypothetically, if you have patients that you do alemtuzumab and they're still having a lot of relapses, can you then put them on some other?
So basically, there's if people had breakthrough disease, they got another cycle. And there was, I forgot the exact number of percentage. Lucas, do you remember that from the top of your head? There was a small portion who needed that, but then basically a 3rd cycle was given. And that would be, is also in the official PI, that you would treat standardly for 2, but if you have breakthrough disease, you would give a 3rd cycle, basically a year after the 2nd cycle. Yeah.
Any PML?
It has not been reported as of yet. So kind of like I will come further down to talk about PML here a little bit, has not been reported on this agent. But it's an immunosuppressant. Any immunosuppressant opens the door for PML complications, so it would be not surprising for it to happen. No? I'm switching topics. As I said, I do this very unelegantly because these are all loosely associated topics, or not even loosely associated. The next one is a miracle. Everyone would check for the right JC virus antibody tests. That's my goal. Let's see if I come a little bit closer to that. And it goes into PML. You know that PML in the world of MS does occur, and we have PML reported in 3 of our MS drugs, 2 of the orals, with low occurrences, 2, let's say, true cases on Gilenya or fingolimab. So basically 2 cases in roughly 120,000 patients or 220,000 patient years. And then please excuse my typo there, that's called fumarat with an A. We have 1 case now which was occurring in fall of last year. And then Tysabri, completely different story. 540 cases in not too different total exposure. And the following slides entirely focus on Tysabri or natalizumab associated PML. So in natalizumab associated PML, we know for a long while that we have 3 risk factors. One is this JC virus antibody test. One is if they had prior chemo. That does not mean if they had prior IV steroids, but prior immunosuppressant, Noventron, Imuran, this type of drugs, and how long they have been on Tysabri. And I show you slightly outdated data because I want to get a point across, and I come to the more accurate data in a second. So basically we have the risk algorithm which goes into these 3 risk factors. And as we move this along, the JC virus antibody status is our most potent factor. And if it's negative, as indicated with green, patients, regardless of prior chemo, regardless how long they have been on Tysabri, have the lowest PML risk, estimated at roughly 1 in 10,000. If we turn over to JC virus antibody positive, you see that this further spreads. So then you have in the middle column those without any prior chemotherapy. They have at baseline already a higher risk in the first 2 years, and their risk further increases after 2 years. If we then look those who had prior chemo, you see that these are the patients who have the highest risk, and the risk increases quite a bit. And you see the spectrum between this 1 in 10,000 versus 1 in 90. So this JC virus antibody test helps us very much to identify and individualize the PML risk in those we consider for this treatment or who are on this treatment. This test has been a little bit kind of like become more, the test results are reported slightly different, and we have more data in that. And the following table is only applicable for those who are JC virus antibody positive and who have not had prior chemo. If you go to the very lowest row here, this is the comparison if you don't have an index. The test is now reported with a so-called index. I don't know where they came up with this funny name. You can think about it as titer. And if you have a low titer, the risk is lower of PML. If you have a high titer, the risk is higher of PML. And if you compare, for instance, in the first column in the first 2 years, the lower risk class for less than 1 in 3 with a positive titer is the same risk as what we report to our patients who are JC virus antibody negative. If the titer, however, is higher, the risk is much higher than what we previously report to them. So for some people, this JC virus antibody test is actually is good news, because we think we estimate their risk now to be lower than we previously thought, and for some people it's bad news because they were identified to have even a higher test compared to when we thought about the JC virus antibody test, a little bit like a pregnancy test. You're either positive or negative, but there's no in between. So we know that with low titers, your risk may be lower than we previously anticipated. I know that is a little bit overwhelming, and I don't need you to understand the details about it or the numbers, but I want you to understand how we use this test in the management of Tysabri patients. So let's talk about the test for a second. It's a two-step ELISA, so if the test results is definite with the first step, the second test, confirmatory test, is actually only optional. There is roughly a 2+% false negative rate, and we do have a certain rate of seroconversion. So what we do in our patients, not that we test this test once and then never again for those who are on treatment, but we continue to test them. And this is the most important slide I want you to understand for this to be a miracle and that we have some improvement on the understanding of this test, because we see mistakes not only with you guys when you have one of our patients as an inpatient, but also with many outside providers. Neurologists are used to test the JC virus PCR. We use this a lot for confirming somebody has a PML as a confirmatory test. The PCR tells us at the time of the test, in the tissue you're testing, you see parts of the virus. So its active replication is part for this test. An antibody test instead is obviously an indirect test. It tells you some things about prior exposure. Doesn't need to be here right now, but it's prior exposure. So the first test, the PCR, we all do when we, in the CSF, we do as a confirmatory test for PML. You can check this in blood and urine as well, but it doesn't give you a lot of data. The blood and urine is often negative in those who do have PML. And the urine PCR is the highest which have been found, is maybe 20 to 30% positive. The blood is more on the 1% level. And the blood is also not positive in those before somebody developed PML, so it has no predictive use for us, and it has no benefit at all for the PML risk assessment in our cohort. The antibody, however, that is what we routinely use for the risk-benefit assessment of Tysabri. So I hope that we have now a much more educated group here and we don't get the wrong tests ordered all the time. Any question to that before we go to another topic?
And if you have PCR positive, doesn't it automatically mean that you can't use Tysabri?
Yeah, but it's kind of like
No, not talking about I understand the antibody, but isn't it contraindication then? I mean, you have active viral replication.
Yes, but that's not what we're looking for. No, so less than 1% of the PML cases would have that, so it's not really useful test for us in those who we consider on Tysabri treatment. I'm going to the third topic, and it's about the gut microbiome and how it relates to MS. And I start with a disclaimer. I'm not even pretending that I fully understand the body of literature which is on the microbiome in MS. What I will do instead, I will kind of introduce you to a few key points of a really excellent presentation we recently had at the Regional MS Summit from Dr. Kasper of the Geisel School of Medicine. And he caught my attention when he already showed the power of the microbiota, which had nothing to do with MS, but that if you do microbiota transplant in a germ-free mice from a mice with fat, then you get a fat mouse as indicated there. If you have a microbiota transplant from a lean mouse, then you have a lean mouse. So for me, this has nothing to do with my behavior. It's something with my microbiome. But that's just as a start point. There are a few fun facts about this topic. So first of all, the microbiota is a universe. There's kind of like up to 10,000 species, the vast majority of which have been not even identified or cultured. We just know that they exist by their genetic fingerprints. And if you think about the gene pool of this microbiota, it exceeds 150-fold the human genome. And roughly 80% of all immune active cells in the body are somewhat linked to mucosal immunity. Each of us carry roughly 600 different species, and they weigh up to 5 pounds. So that's an organ by itself in the universe. He then went on to something which we have kind of like thought about for a long period of time, the hygiene hypothesis in MS, and kind of like visually illustrated by the upper panel, where you kind of like see the inverse relationship between the distribution of autoimmune disease and the distribution of infections associated with substandard hygiene conditions. Maybe a little bit hard for you to see here the lower panel, but basically what it shows that on the left side panel, a reduction over the decades in common infections corresponding with an increase of different autoimmune diseases in the same time frame. If we then turn our attention a little bit more toward the MS specific area, many of you likely will know that there's the so-called EAE model. So that's an MS-like condition which we can induce in animals. So we have an animal model for MS, it's called EAE. And basically these mice are given in so-called immunization. There are different ways of doing it, the direct and the non-direct way. I will not talk much about this here today, but basically within roughly 10 days of this immunization, you have a mouse which then illustrates neurological condition, and the severity of the condition is measured by the severity of the weakness, the leg weakness of the mouse. And as illustrated here, they have similar to in the human world, we have an EDSS score. In the animal world, they have an EAE score, telling the degree of neurological impairment. What they did now is they took mice and transplanted the microbiota of human MS patients, and they saw that they could alter with that the severity of the EAE in these mice. So basically do a stool transplant from a human into an animal model, and you alter the severity of the disease in the mouse. As illustrated here in red, so the severity of those exposed to the gut flora of MS patients have a highest degree of neurological impairment. And then I'd like to introduce you, or he introduced us to then one of their pets in their research is kind of like B. fragilis as a common part of this, between this 400-600 species, which is a small amount for the vast majority of our microbiota. And it has these 8 capsular PSAs, which have functioned for the bacterium, but also have immune regulatory properties. And then he showed that PSA-induced T regulatory cells actually affected the severity of EAE as well. And it basically has a protection effect, as illustrated on the left panel, with lower severity degree of the EAE in those cases. And then you see also an effect on the cytokine profile. He also showed here this data where that the PSA of this common bacterium has both prophylactic as well as therapeutic protection in the EAE model. Basically, after induction, it reduces prior to induction, it reduces the severity of the EAE, as we have seen on the prior slides. But even if you give it after the induction of EAA, you can reduce the severity of the EAE when you provide this afterwards. This is something which I believe we will learn lots more about in time to come. This is kind of like the beginning of an interesting chapter for us and may tie immunity to the immune system of the gut, which we may have all not really anticipated that much to have a big influence in the world of MS. So I turn our attention to topic number 4. Topic number 4 is how do activated immune cells enter the brain, and neurologists may have a little bit simplified understanding from that. So I think we all think most of the time for some funky reason the blood vessel becomes leaky and these activated immune cells from the periphery can enter the brain. Or we even think that these activated T cells are kind of some super bullies that they can get through the tight junctions and just kind of bully their way through the blood-brain barrier. Immunologists look at this a little bit more sophisticated, and I'll show you here some data and nice description from Joan Government, who works here and is the department chair of immunology. And immunologists think about 3 entry routes, and the first one is actually a blood CSF barrier, which is being where these immune cells come through. In the choroid plexus, basically from the blood cells in the choroid plexus into the stroma, into the CSF. So a blood CSF barrier. There's a second blood CSF barrier and the meninges into the subarachnoid space. And then there is a blood-brain barrier deeper in the brain parenchyma associated with the small venules. And if you look at this on a more granular level, the activations happens as illustrated in the outer corner there in the periphery. And you may wonder kind of how does it happen that in the periphery something is activated against some structures in the brain. There's certain hypotheses about this. So basically T cells are somehow presented myelin or myelin-alike epitopes. There's one way that you can think about that APC cells from the CNS somehow make it to the cervical lymph nodes and then show activating T cells. Another alternative would be that you have soluble myelin or myelin epitopes which make it somehow out of the CSF, and then from resident APC cells in the lymph nodes are then presented to the T cells. And then there's obviously the whole chapter about molecular mimicry, that something which looks alike and behaves alike is being presented, and there's a misguided response then. In any case, these activated T cells make it into, let me try to do this here with a pointer, make it into the bloodstream. The first entry route is not the blood-brain barrier, but the first entry route is the blood CSF barrier, and it's either in the choroid plexus or in the meningeal subarachnoid space. They're then reactivated, these T cells, by epitopes, myelin epitopes in the CSF. That causes activation of subpial microglia cells, which then again triggers in an active approach distal activation of distal microglia cells, but also distal blood vessels. So it's an active process to get the blood vessel leaky, if you want to put it this way. And that kind of this active process is not only to make it leaky, but to kind of like have some epitopes then the activated T cells can knock onto and then go over the blood-brain barrier. And then there's a cascade of further steps, which in the end then causes CNS demyelination. So our understanding of, or my naive understanding of the blood-brain barrier becoming somewhat leaky or T cells being the super bullies is kind of not necessarily how the immunologists look at this process, but it's rather a very active and sophisticated process, which probably we don't fully understand. But then we have also recent, just last month, we have learned that there are indeed something which we haven't known about before, that there are vessels in the CNS which have all the hallmarks of lymphatic cells and carry fluids from, as well as immune cells from the CSF to the deep cervical lymph nodes, which may be another connection, may explain how the myelin or myelin-like epitope makes it to the cervical lymph nodes. That is surely only the beginning of a lot of body of research which will come to this topic in MS and other autoimmune diseases, but it's clearly an interesting additional point we're just starting to learn about. Unless there are any questions, I will move on to my last topic, which is entitled I Love Echo. What's that mean? So, Project ECHO is a standing trade name which stands for Extension for Community Health Outcomes. It's a work which originated in New Mexico and has shown to improve outcomes in different diseases like hepatitis C, HIV, chronic pain. These are weekly case-based tele-learning opportunities for rural providers, and they're meant to build confidence and capacity to treat challenging diseases. And in the end, there's a little bit of thought of a snowball effect, that in a rural area you have somebody who's better educated than other people in this rural area on this topic, and then can provide and translate this knowledge more. Important part to also motivate providers to in rural areas to participate is that CMEs are being provided. And at the UW, there are standing ECHO projects for hepatitis C, for HIV/AIDS, and for chronic pain. And since fall, we have now a pilot project on MS as well. And the pilot project in MS is a collaboration of our center with the National MS Society, partnering with rural providers in underserved areas to increase their capacity to treat and manage MS. The funding comes from a grant from Medtronic, and the team lead in our team is Gary Stobie on this. And sorry, I should explain, maybe not too dissimilar what I'm looking in here right now. Patients, providers are provided with this device which allows, from their point, very easy hooking up to their computer system to be able to be participating actively in this video conference. It started as a 2 times 12-week cycle with weekly 1-hour sessions. 15 minutes of those are assigned for short practical didactics, followed then by cases. Many times the cases are actually brought up by the rural providers for consultation, and then case discussions with the expert team. So who participates in our projects? We have people from Montana, Idaho, Alaska, and Washington State participating. The original ECHO projects often are geared towards primary care physician. We actually try to replicate that as well, because in rural community often you don't have a neurologist and you have a primary care physician who is taking care of the patient with MS for the vast majority. But we were a little bit surprised by the interest we got from rural neurologists by it. So we have actually an unproportional high degree of local rural neurologists participating, but then also all the other specialists as listed here. And this is how that looks like in real life. So in our team huddles across a table, and we are kind of video conferenced in, and then we have video conference from all the different locations, providers on the other side. And we have a face-to-face discussion with them on this project. The goal again was to improve the capacity of healthcare providers to serve people with MS, to increase their knowledge, their confidence, also to connect them better, both the provider as well as the patients, to resources from the National MS Society, and to see if this model is sustainable and if it's effective for these objectives. Our status update is that this project is actually now in its 3rd round, and we're gathering funding for continuation of this project. Over time, our sessions have changed a little bit. There was more effort to make them even more interactive. to have less didactic sessions, and to have these didactic sessions more case-oriented, or at least bringing up in a case format. We are fine-tuning the outcome measurements, and there are the first sites on the East Coast who are replicating this project. Currently, from our first round and the pre-designed round, we are still in the process of collecting longer-term outcome data on this. We have, however, pretty positive feedback from our participants, healthcare participants. They do appreciate the interaction with the expert panels, the consultation. We have seen many of those patients actually which are reported, so if there were particular complicated patients, some of them have made it in person to our clinic for further in-depth evaluations. And the participants appreciate the focus on real-life aspects and clinical care. So that was my 5 amazing things about MS. I leave you with kind of introducing you to our team. So we have an interdisciplinary team who doesn't know that yet, that we moved at this point 3 years ago to Northwest Hospital campus. Must have been living under a rock, but we have neurologists, rehab doctors, psychiatrists, we have fellows working with us. One of the things I'm noticing on a real life aspect as well, when you're referring patients to us, do not refer them to Northwest Hospital. We are UW. We are located as Northwest Hospital campus, but I saw more recently that patients who have been inpatient and you guys want them to us seeing them on an outpatient basis, we are UW clinic. Just our location may be misleading for you as it is for other people. Don't refer them to Northwest Hospital, but to us at the Northwest Hospital clinic. I'm open for any questions you guys may have.
So in the beginning you had lists of various new therapies. So one of them was fingolimab, or?
There was not the new one. The fingolimab was listed as one having 2 cases of PML, but I'm happy to pull up the slides. So is this what you were thinking about?
So
Yeah.
there's something called liquidomab, is that?
Liquidomab is not yet FDA approved. They did have actually weekly positive clinical trials, but they were not overly confident about the outcome on the relapse rate. There was roughly, I forgot the details now, 20-25% reduction on relapse rate, and that made them go back to the drawing board instead of submitting it to the FDA.
So, and do you think that's because of the mechanism they think they're targeting? This is what do we know?
Kind of, there is some data and some discontent actually in the MS community that they think that is actually the agent which may have the most promise for us for repair and regeneration, but they went back and kind of designed another trial looking at the standard outcome measurement of relapse rates, because that's so commonly known. That likely will go back to the level of mechanism, but the company was a little bit surprised by the weak overall, less than anticipated effect on the relapse rate.
This is an innate immunity.
Yes. So it's not part of our repertoire at this time, lacrilimab. Any other questions?
2 questions, Annette. First of all of these drugs that are now in use with clinical populations, do they have any efficacy in EAE, experimental autoimmune encephalomyelitis?
I think in the end they all came by showing that they have demonstrated. So you always go from bench to kind of clinical care. Some of them kind of were, if we go back to the Copaxone, was actually designed as a drug which was felt to stimulate EAE, and then they, because it's resembling the myelin, and they designed the drug to be an EAE inducer, and then they found it's protecting it, and so kind of like by chance this was found as an agent to eliminate, to kind of alter the course of MS. But in the end, you always have Petri dish and EAE data on all of these
I asked that question because EAE has always struck me as a terrible model for MS. Absolutely, almost worthless because it's a single event, and yet most of these are effective at preventing relapses, not the initial event. So do you really believe that EAE is a good place to look for drugs that are effective in MS?
I think we have learned a lot from this EAE model, but this EAE model is obviously not without limitation. There are actually, if we think this model, that is not correct. We have different type of models. We have T4 and T8 models. And so kind of like, but most of them, there are some models which are actually more seem to replicate the progressive phase of the disease, but the most commonly used one is a single relapse, just like you're describing. And yes, we've learned something from it, but we do know it has limitations. So it's not a replication of the relapsing remitting MS as a clinical course over time, for sure not. Because it's you do something, you have one event, it's not this relapsing remitting course over time. You're entirely correct.
My second question was the drug that you talked about that's an IV infusion. I forget the name.
Alemtuzumab.
This thing, yeah.
Yeah.
Why would anyone ever submit to that drug?
You mean in light of these safety issues?
Yes.
Yes.
Shoot me first, right? I mean.
It is something which makes even us as provider hesitant, but at the same time I have patients where I kind of, when this drug came out, I was flagging them for like, oh, maybe I'm going with them. 2, maybe 3 patients, and have not dared to really do this step even with those guys. We have had at least discussions about this because they basically get worse in front of your eyes, and whatever I'm doing, I cannot really help them very much. And so this is in hope that there's something helps, but if you see the safety profile to it, if you have not seen any of our providers yet jumping somebody moving forward. We had a recent case from Gary's where if we had been a little bit further in the process, because obviously there's a lot of logistics associated with it, that may have been somebody who was recently hospitalized, who was basic burns to anything, has enhancing lesions on Tysabri, no response to steroids, steroid sarcosis, just to make life a little bit more complicated, and then plasmapheresis, enhancing lesions, no response to plasmapheresis. That was a patient where where we as a team discussed if that potentially maybe somebody was looking. But you're right, we as a team are hesitant on that as well, for obvious reasons.
Call a lawyer first.
Tom.
So how often do you get MRIs follow patients?
Depends a little bit on the situation. Let's say somebody is fairly newly diagnosed. Let's define fairly newly diagnosed as within the first 5 years or so. Regardless what treatment they're on, I typically do it routinely once a year, because we know that the clinical picture, what they report to us, what we see on a neuroelectrical exam can fool us, that somebody can be insufficiently controlled with these drugs. And now it's no longer I have 1 or 2 drugs, you take it or you leave it. Now I have a repertoire of these 12 drugs available with different potency, different safety profiles, and we know if there's a writing on the wall, patient will get worse. So in the beginning, I would say in earlier disease, roughly once a year. Patients who are on Tysabri routinely once a year need an MRI for safety surveillance. Multiple PML cases have been found on routine MRI surveillance, so that's part of the TOUCH program, it's part of the routine surveillance of people on Tysabri. Let's paint the picture a little different. Somebody who has 20 years of MS may or may not be on a treatment. Do I do frequent MRIs? No. We know that especially in advanced MS, there's often the MRI doesn't change that much anymore, and that there's obviously certain things we always need to be aware of which we are missing on the MRI, where we have basically a blind spot. We know from biopsy materials that the vast majority of people with MS have cortical involvement. On a routine MRI, you will not find that, so you will not see the changes, but probably more of importance for somebody who has 20 years of MS is that there are neurodegenerative changes or seem to be the predominant feature of that disease, and that's not associated with a lot of MRI changes. But we have multiple examples of highly active patients even after many years of disease, or even in an age group where you don't anticipate that either. So it's probably worth to do it occasionally or in certain situations. Typically when we really think like that helps us in medical decision making. We're not doing this just for, okay, yet order another test and be happy about and think you have done crossed all I's, dotted all I's, crossed all T's. So it's just kind of like if there's medical decision making dependent or contributing the MRI. Not sure if that helps you or answers your question, but it is not a black and white answer. Other questions you guys may have? Oh yeah, gosh, obviously I forgot. How do I do this again? Do you think the vagus nerve could have a role somehow in communicating immune information between the brain and the gut? Oh, I don't know. Has somebody a good answer to that one? I don't know. I'm not sure how much. Let's say I believe more in some cells or some factors kind of floating some way. I cannot describe it better, and because of that this new lymphatic system makes more sense to me, but I don't know if I have a good answer for you guys here. Other questions? Okay, thanks for all for coming.